in next 1 minute. So I'll start with the introduction. So good evening, everyone. On the behalf of Pediatric Oncology Chapter, it is my pleasure to welcome all of you today for the national webinar focusing on an important and increasingly recognized intersection in pediatric hematology, that is autoimmune hemolytic anemia and inborn errors of immunity. We all know that autoimmune hemolytic anemia, although uncommon in children, often presents with significant diagnostic and therapeutic challenges. And in recent years, we have learned that a subset of children with AHA, particularly those with recurrent, refractory, and multilineage autoimmune cytopenias, may actually have an underlying immune dysregulation syndrome or inborn errors of immunity. Recognizing this important link, it is my privilege today to introduce our very distinguished and esteemed speaker, Dr. Mukesh Desai sir. He is a senior pediatric hematologist and an immunologist, head of uh, immunology department in Wadia Hospital, and he has extensive experience in the diagnosis and the management of complex hematological and immunological disorders in children. And we are very grateful to him that today he accepted our invitation and he is here to teach us about this topic. This is a difficult topic, and I'm sure this session will provide wonderful and valuable clinical insights for all of us. Sir, floor is yours. Thank you so much.
Good evening, everybody. Thank you, Shweta, for this very generous introduction. I'm also a learner and not here to teach anybody. I'm just sharing a little bit of my experience in inborn error of immunity. What I hope to do in the next few minutes is to give you an introduction to immune cytopenia in inborn error of immune deficiency. It may not always be autoimmune in origin. There may be a mixed, there may be multifactorial etiology in having this cytopenias, which you very commonly come across in patients of inborn error of immunity. Firstly, I must thank all the people I've come in touch with at Wadi Children's Hospital, the Department of Inborn Error of Immunity, to my mentor, Dr. Karim Bhai, Vijaya, to Vaishnavi, to Akshay and Prasad, who have really held the department together. I think I just am privileged to present some of the work which has been done by them. Now, we all know it's very important to make a correct diagnosis. And I can give you example of this young doctor who was an intensivist, developed at the age of 23 a neutropenia with an absolute neutrophil count of 150. Now he was marrowed, a cytogenetic was sent, everything turned out to be normal, and he was labeled as unilineage cytopenia myelodysplastic syndrome. He was given GCSF, to which he had an excellent response, and subsequently, like a typical doctor, he forgot to take his GCSF, again had severe neutropenia, ANC in the range of 100 to 200. Now, this gentleman went to another hematologist and they again marrowed him, and it showed some chromosomal abnormality which were highly non-specific. Now, in this setting, when he came to me, what was important in the history we got was that he keeps getting these oral ulcers right from his childhood when he remembers. That gave us an important clue that the problem is not since 23 years of age. This is probably going on for a long time. And on inquiry, he said he has been operated for an atrial septal defect. Now, this was a very important clue for us to tell us that we are dealing with a syndromic variety of congenital neutropenia, and we suspected a glucose 6 phosphatase 3 deficiency, which it turned out to be. And we put him on an anti-diabetic Jardiance, with which his absolute neutrophil count went from 150 to 4,800. So I think it is very important to make a correct diagnosis. An anti-diabetic removed the metabolite which was toxic to the bone marrow, and he showed a dramatic response. The same is true of a child born at Wadia Children's Hospital having congenital mitral regurg and tricuspid regurgitation, cryptorchidism, delayed puberty, was referred to us after he was 18 years old for neutropenia. Once again, if you look at the picture, you will find he's got a very prominent subcutaneous vein with a heart problem and cryptorchidism. Once again, we clinically suspected a glucose 6 phosphatase 3 deficiency, put on the antidiabetic, and he also had an excellent response with dramatic improvement in his neutrophil count. So I think it is very important to make a correct diagnosis. If you look at the situation of inborn error of immunity, they are increasing by leaps and bounds. When we started our department, there were approximately 99 inborn error of immune deficiency in 2007, and last year in we had about 480, and now in the 2024 IUS classification, we have more than 555 inborn error of immune deficiency. A very important sentence which struck me in this was that the author had written that the current update will likely be outdated by the time of its publication. So this is a very important sentence which tells you how rapid the pace of progress is taking place. Now, a large number of immune dysregulatory disorders come with autoimmune disorders, and autoimmune cytopenias is one of the most common presentation of autoimmunity seen with inborn error of immunity. Now, we always say that immune deficiency are rare individually but common as a group. But I feel that it may not be a true sentence to make. Actually, there may be more common than what we really think. It is definitely more common than hemophilia and other genetic disorders. So, friend, what is inborn error of immune deficiency? I think we used to call it PID. The nomenclature has changed, and it could mean susceptible to infection, autoimmunity, malignancy, and today we'll keep the focus on autoimmunity. Some of the principles which we use to make a diagnosis in any patient of inborn immunity is to go beyond the immediate diagnosis. We establish a plausible pathophysiological process and then try and connect which arm of the immune system could be affected. But I think the most important thing is going beyond the immediate diagnosis, asking this fundamental question: why has this child developed an autoimmune hemolytic anemia? Why is this child developed an Ivan syndrome? Why is this child developed an extended Ivan's? And these are the questions which lead you to underlying inborn error of immune deficiency. We have a huge cohort. There are, by 2023, we had 853 monogenic defect, of which almost all the subgroups present with autoimmune cytopenias. So today we'll keep the focus on cytopenias in inborn error of immunity, and I'll take you through some of the aspects of it, tell you mechanisms and what therapeutic challenges we face, which and how to use some of this knowledge to select a therapy which is available. Well, this cartoon will show you the type of immune deficiencies which you see in patients of inborn error of immunity. If you see on the upper side, you would have realized in patients who have immune dysregulatory disorder, now called primary immune regulatory disorders, they have more of autoimmunity, then they would have less of infection, while those who had immune deficiency state, they have more of infection, less of autoimmunity. Now, you would have noticed that both combined immune deficiencies, antibody deficiencies, phagocytic defect, immune dysregulated disorders like HLH, complement defect can all come with multiple autoimmunity, of which the commonest is autoimmune cytopenias. If you look at the primary antibody deficiencies, then you would realize that autoimmunity is very, very common. And I think besides that, you have to know that more than combination of one auto antibody or one autoimmunity makes it likely that you are probably dealing with an inborn error of immune deficiency. Now, this is a small study which was done by Dr. Vijaya at our department, where she studied 57 patients of autoimmune disorders, at least those having more than one autoimmunity, and the results, and she did an exome for all of them. And the results were very striking. We had 50% of the patients having pathogenic variant among PIRD genes. Additionally, 9 patients had a VUS in PIRD genes related to the phenotype. So you can imagine how high the possibility of an underlying inborn error of immune deficiency is. And today we are very liberal in asking for an exome wherever there is autoimmunity which is persisting, or a more than one autoimmunity, or if there's a family history of autoimmune cytopenias, autoimmune disorders. So of the 57 patients, 60% had hematological autoimmune disorders. And I think this is a very common thing which we come across. And the commonest cause were LRBA deficiency and STAT1 gain of function in our cohort. So as you can see in this particular cartoon, autoimmunity may include hemopoietic autoimmunity like autoimmune cytopenias. You can have lupus, you can have vasculitis, and you can have arthritis. And there are multiple genetic defects which may uh, overlap and have a combination of any of these factors, as you can see is shown over here. So here it's autoimmune cytopenias. Here the fast and fast ligand, which is the ALS cohort. Then you have LRBA STAT3 gain of function, and you have here with antibodies and combined immune deficiency, NF-kappa B defect, which can come with you. So I'll just quickly run you through, show you humoral primary antibody deficiencies, and all of them can come with autoimmune cytopenias. If you see cellular immunodeficiencies, you have Wiskott-Aldrich partial dejoint. Okay, very often can be missed because they don't have phenotypic feature, and you have to be really extremely aware to pick up a partial dejoint. Then you have STAT3 and STAT1 gain of function, which can all come with multiple autoimmunity, including autoimmune cytopenia and ALS-like feature. Now, how common is autoimmune cytopenias? Almost 31% of the cohort of autoimmune disorders in patient of inborn error of immunity in the French cohort were having autoimmune cytopenias, followed by gastrointestinal disease. So autoimmune cytopenias are the most common presentation of underlying inborn error of immune deficiency. If you notice over here, the antibody deficiency and the T cell deficiency, both of them, the incidence increases with age. And so you should be prepared that even in an adult, you should not discount the possibility of an underlying immune deficiency. If you notice further, in Evans syndrome, almost 40 to 50% of Evans syndrome have underlying inborn error of immune deficiency. So today, we have a dictum in our clinic or at our at Vade Children Hospital that every child with Evans syndrome will have an exome done so that we pick up this underlying inborn error of immune deficiency, because picking up this underlying deficiency may help you and may alter the course and the change the treatment plan for that particular child. Now, why it is important to make a diagnosis of autoimmunity and underlying inborn error of immune deficiency? Because those patients who have autoimmunity with inborn error of immune deficiency have poorer survival compared to those who don't have autoimmunity. Now, you all know that it's once when we were in Paris, there was a child of XLA who had an autoimmune hemolytic anemia, and I think Dr. Kariboy asked Alan Fisher that how can he produce autoantibodies when he can't produce antibody? So that's an immunological paradox, and I think all of us would agree the person who solves this paradox will probably in line for a Nobel Prize, not Peace Prize. That is, Trump is in line for that. So we all know that the immune system tolerates self-antigens, and the tolerance is central tolerance as well as peripheral tolerance. We know the thymus is important for central tolerance, which is taught to it that T cells are educated by the AIRE gene expression, and deficiency of it causes upset disease. Then we have the peripheral tolerance, where T regulatory cells play a very important role. And you would have noticed over here that patients who have interferonopathies, you all know lupus is an interferonopathy, which is an innate molecule. And you would realize that they develop the most classical adaptive autoantibody related problem like autoimmune hemolytic anemia, autoimmune thrombocytopenia, and so forth. Complement defect, a large number of complement defect come to you with lupus-like presentation besides infection. The defects in B cell maturation, we all know about ALS, apoptosis defect, severe lymphopenia, all of them can cause immune dysregulation and result in autoimmunity, including autoimmune cytopenia. So I'll quickly run you through some of the cellular defect which can cause autoimmunity, like a combined immune deficiency, DGeorge, Visco-Talrich syndrome. Then you have the classical antibody deficiency, of which the classical example which we found in our code was CTLA4 and LRB and TAT1 gain of function. Then we have immune dysregulatory disorder, HLH, which can come with pancytopenia and very often confuses the differential diagnosis. Lymphoproliferation, the classical example is XLP1, XLP2, CD27, CD70 deficiency. The bone marrow failure in children, especially, is now included in the IUIS classification. So those who are in immunology pure will also have to know about this disorder, and they would realize that a lot of them can mimic sometimes immune cytopenias, or they may be combined with an immune cytopenia. So you need to be aware of it. Myelodysplastic syndrome, especially GATA2 deficiency, you should be especially aware, can come with autoimmune cytopenias as well as myelodysplastic syndrome. And then you have susceptibility to infection, malignancies, which can all make you prone to getting uh, cytopenias. Now, this is a very complex cartoon, but I think this cartoon I will come back to you telling you that this is the reason for refractory primary ITP in most situations. So here it deals with what is happening in the spleen, where you have long-lived plasma cell, you have memory B cell, and these molecules which are highlighted, they can all be targets for us to treat patients of ITP, which I'll tell you when we talk about the therapeutics which we have. Then we have the central tolerance. This is the peripheral tolerance. And then we have germline mutation like the CTLA4 and STAT3. And you have somatic mutation. Now, this is something which you are going to see more and more commonly. You're going to see DNMT3, TET2, and ASXL1. These genes are going to play a very important role. Less so in children, but especially those who already have an hypoplastic anemia or MDS, addition of this particular mutation would be very interesting to see how they cause more cytopenias and progression of the disease. Heterozygous TET2 mutation and germline TET2 mutation can come with both autoimmunity, myelodysplastic syndrome, and susceptibility to infection, and can sometimes occur early, but can happen also very late in the fifth and the sixth decade. So keep your mind open to these possibilities. Infections, just tell you the mechanisms, and you know that the platelets also express receptors which are important for getting infected with HIV, rotavirus, CMV, adenovirus, and EBV, and various known mechanisms like molecular mimicry, bystander effect, and so and so. The secondary ITPs can be because of defect in the Treg or less of T regulatory pathways, as you can see the molecules shown over here. And these are now called tregopathies, and we may use the term tregopathy for some of this defect. And then we already have secondary ITP, which is because of a chronic lymphoproliferative disorder, more in adult, but sometimes you only see in adolescent. Now, I told you we should never get confused about autoimmune cytopenias and possibility of an inherited thrombocytopenia or an inherited bone marrow failure syndrome. And here is just to show you that sometimes patients of inherited thrombocytopenia with molecules which you all know, GATA1, RUNX1, can come to with cytopenia which may exactly mimic your autoimmune cytopenias. Now, this is a patient who came to us with varying thrombocytopenia, varying cytopenia, leukopenia, and would have lot of autoinflammatory symptoms, fever, very high grade, oral ulcers, and he would develop a rash on the body, which would then disappear after a few weeks. And we really suspected that probably he could have a Wechsler syndrome like an autoinflammatory phenotype. But then we realized that we did an exome and a repeat bone marrow where he had a trisomy 8 and he had a mutation in RUNX1, which was a known described mutation in familial platelet disorder with susceptibility to myeloid leukemia. So this can come at any age. We had a second child who at the age of 1.5 years was having thrombocytopenia, initially very severe, now relatively mild in the range of 100 to 80,000. And he also suspecting a viscot-Ullrich, but it turned out to be an same RUNX1 mutation. So you need to be extremely aware Because in case you're going to transplant them, you have to also check whether the sibling who is likely to be donor doesn't have the same mutation. So myelodysplasias can very characteristically mimic an autoimmune cytopenia, and we all know that acquired aplastic anemia can also be a problem. So this is a very interesting cartoon which I have taken from the French study on genomic landscape of inherited bone marrow failure syndrome. And you will realize that all of this can come to you with unilineage or multilineage cytopenias and can behave like an autoimmune cytopenia. So you need to be extremely aware. We have a patient of SAMD9 ligand who came to us with almost an HLH-like picture, and he had a brain calcification. So we thought that, oh, he's got an Aicardi-Gouttière syndrome, and turn out to be a SAMD9 ligand with monosomy 7. So these are very challenging things. GATA2 can present with neutropenia here, monocytopenia later on, and it's a very interesting mix. So I think today any child of pancytopenia or cytopenia would demand that he would need an exome to be done. So this is the child I was talking to you about, which has been published of 79 ligand, where he has brain calcification, looked exactly like an Aicardi-Gouttière syndrome. He had an HLH-like presentation with big liver and spleen, and his genetics showed that he had 79 ligand. Father is also a carrier of the same thing. So ALS, you all know about ALS, Smith-Canales syndrome. Uh, the central regulatory AIRE gene defect upset. Then we have the regulatory T cell defects, where the FOXP3 gene, CD25, CTLA4, LRBA. I've crossed them in yellow bars because these are the patients which we have come across and made diagnosis. And then you have the one where you come get with colitis, especially IL-10, IL-10 receptor, and RIP kinase. So this is just to show you somebody comes to you with thrombocytopenia or autoimmune hemolytic anemia, the incidence of which is extremely high in patients of ours and has got lymphadenopathy, especially bull's neck like this, or a massive splenomegaly. And the histology is characteristic, and the histopathologists tell you that, oh, there are infiltrates of cell which are double negative. You would make a very correct diagnosis of ALS. I think this all of you should make a spot diagnosis. Now, this is a child who came with a very high blood count, 126,000. If you look at the peripheral smear, it would look like a mature lymphocyte. Somebody who doesn't know the age of this child, who is 9 months old when he came to us, would make a diagnosis of chronic lymphocytic leukemia looking at the peripheral smear. But when the flow was done by Dr. Manisha, she told us that 83% of these cells are double negative T cell. That was the clue that this patient has an ALPS, and he had an homozygous fast ligand, which is one of the first patient of homozygous fast ligand, which was published by the French group Dr. Frederic Lecoq. There's another sisters who had ALS, and the beauty is that they respond beautifully to sirolimus. They have an excellent response to sirolimus. This is just to share with you the incidence of cytopenia in ALS is extremely common, but so also is lymphadenopathy, lymphoproliferation, in short. So this is just to show you two examples of patient of LRBA deficiency. This is a child who came to with thrombocytopenia and diabetes mellitus, had chicken pox, and we lost him because he couldn't undergo transplantation. And this is a child who was treated for almost 4 or 5 years as an ITP, and then developed an autoimmune hemolytic anemia, came to us, and then we did an exome which showed she had an LRBA deficiency. So this is a very interesting child. I'd like to dwell upon this child who came at a very young age of 3 when he had severe thrombocytopenia, a platelet of 1,000, and had lymph nodes and liver and spleen enlarged. Now we somehow got a lymph node biopsy suspecting that he could have a leukemia because the bone marrow was normal, and the lymph node biopsy was inconclusive, and we were not reaching a diagnosis. The child was very severely thrombocytopenic and bleeding and required a lot of support. We sent an exome which showed us that he had a gain of function STAT3 mutation. So it fitted in an ALS-like picture in gain of function STAT3 mutation. And so we used tocilizumab, which blocks the IL-6 receptor. And there was a very dramatic response. You see the platelet count, which used to be 6,000, jumped up to 1,26,700. And he had a normal. But was the effect of tocilizumab would go away. Now, since we knew that we can block the JAK-STAT pathway, we used a JAK inhibitor, somehow managed to get ruxolitinib for him, and in a matter of week, his platelet count, which were very low, again became normal, and he remained sustained for a very long time, to the point that he even developed polycythemia rubra vera. When baricitinib came at the time of COVID and it became very cheaper, we shifted him to baricitinib, and we gave him a drug holiday because it was completely not a long time. And now we have restarted him again on baricitinib because of relapse after a year or so. So he is now 9 years old and doing exceedingly well. So here, once again, I feel not only making a correct diagnosis, gave us a molecular target to hit and with a very dramatic effect. So I think this is a very interesting child, which taught us a lot of things about how we can modulate, since a lot of new molecules are becoming available. This is our first patient of CTLA4 deficiency who had an ITP. He also had alopecia areata, as you can see, and he had an IBD. He was put on sirolimus and abatacept and subsequently underwent a bone marrow transplant at Valley Children's Hospital successfully. Now, APDS syndrome comes with a CVID-like phenotype, and they also have a high incidence of autoimmune cytopenias. But what I want to just impress you upon is that sometimes they also come to you with an aplastic-like picture. Now, one distinguishing feature which would help a histopathologist or a hematologist make the distinction that this is probably an APDS syndrome and not an hypoplastic anemia is in patients of APDS syndrome, the bone marrow biopsy will show you a lot of these clusters of CD3 positive cells. So you'll see clumps of CD3 positive cells, and this presence of clumps of CD3 positive infiltrate is the clue to tell you that you are dealing with an APDS syndrome and not an hypoplastic anemia, because you don't see that in hypoplastic anemia. And this is a slide which was shared by Dr. Koneti Rao, and I have his permission to show it to you, so that I thought this was a very interesting feature which our histopathologists, if they know, they can probably help us pick up an APDS syndrome. Now, APDS syndrome is a gain of function. So by using an inhibitor, we can block the effect of APDS. There are two drugs in pipeline, leniolisib, where the data has already been published, preliminary data, which shows that the patient do exceedingly well. If we can't, since we don't have access to leniolisib or idelalisib, we can use sirolimus for this patient with some very dramatic improvement in the cytopenia. Looking at all this complex thing, telling you about CVID, we now have about 10 to 20% of CVIDs where we have monogenic cause found. And we know all these molecules, which I'm not going to go through, which you can target, which you should be aware of, because in future you will have these targets available. So antibody deficiency, primary antibody deficiency and autoimmunity is an immunological paradox, as shown by this 2.5-year-old boy who came to us with a pericardial infection, UTI, and an ITP like illness. So he had an XLA doing exceedingly well now on IVIG. Now, autoimmunity can be directed against multiple sites. So, autoantibody to anti-cytokine antibody is a major thing which we should all be aware of, because they can come to you with multiple different kind of susceptibility to infection. If you have anti-GM CSF autoantibody, you can get pulmonary alveolar proteinosis. If you have an interferon gamma antibody, you are prone to getting tuberculosis and a Mendelian susceptible to mycobacterial disease. If you have it against neutrophils, you get it in Felty's disease. So there's a host of cytokine-related disorder which is being recognized, and Dr. Stephen Holland is the one who has done a lot of pioneering work in this. Now, for all of us who suspect an lymphopenia, which is idiopathic CD4 lymphopenia, it might be interesting for all of you to know that we are focused on the neutrophils and platelets and the red cells, but lymphocytes also have autoimmune lymphopenia. And some of the causes of idiopathic CD4 lymphopenia are because of an antibody to CD4. And I think this is a very interesting concept which was recognized when they found a child with ALF having a severe CD4 lymphopenia. When they worked up, they found that he had an antibody to CD4, and that led them to start looking for autoantibody in the whole cohort of CD4 lymphopenia. And so the importance is that you can target them with rituximab. So tell you the story of susceptibility to COVID-19. you would always recognize that 10% of COVID-19 patients or 3.2% of patients who had severe fulminant COVID-19 had monogenic defect, and some of them were because of an autoantibody to interferon alpha, which was seen in 10% of the population. So this is a very interesting thing, an autoantibody to interferon alpha, making you prone to getting a severe fulminant viral infection like COVID-19 and resulting in mortality. But it can be targeted by using rituximab. SPEN-CD, which is an uh, coming to us with an Ivan syndrome. Just to show you, a child of Ivan syndrome, you have an it's a type of interferonopathy. So you have large number of molecules which can cause an accardic Gouthier-like syndrome, which is nothing but an interferonopathy. The link is directly with lupus. Lupus is also an interferonopathy, and they can develop autoimmunity, the classic autoimmunity we see in patients of lupus. What therapeutic options we have in treating patients of autoimmune cytopenias or autoimmunity? There are a lot of the therapeutic options which we can talk about. So some of them I've already mentioned to you. ALPS mTOR pathway is very important. In CGD, where the infection has been adequately treated, but the lesion doesn't disappear, then use of steroids can be very helpful. STAT1 gain of function and STAT3 gain of function can be treated with JAK inhibitors. IL-6 inhibitors were required. HLH, you have JAK inhibitor, you have alemtuzumab. Then MSMD, those who have and can be used with cytokines like interferon gamma, glucose 6 phosphatase 3 sorry, I can't pronounce this very well, empagliflozin. So there are a lot of these molecules which are targets which are available. In short, you're doing some sort of immunomodulation in this patient. APDS, idelalisib, or this is for blocking the APDS pathway. So I think it's a very exciting time for all of us. We have a lot of options of treating. And we have a lot of options of modulating the antibody production. As you can see over, we have molecules like ibrutinib, which is used for in chronic lymphocytic leukemia, which can be used in patients of autoimmunity. So maybe some of your ITPs in future you might be treating with ibrutinib. We have drugs like BCL2 antagonists. Then we have a lot of monoclonal antibody. People are using rituximab like water. For every patient, it is better to use upfront than later on. Then you have bortezomib, you have daratumumab. I don't think we have yet to use daratumumab effectively for immune modulation and immunotherapy. You have anti-BCMA antibodies, you have bispecifics, you have a host of antibodies which are being recognized, which we can use, and some of them have been used in off-label conditions with some very dramatic effect. Abatacept, especially useful in patients of even now approved for graft-versus-host disease, but for LRB and CTLA4 deficiency. So a lot of these things are available to us. So I come back to this very complex cartoon which I have shown you about patients who have refractory primary ITP can be targeted by using CD19. So you can even use CAR T cell therapy. You heard about that in the, I think the Illuminate conference, somebody from Israel talked to you about. We can use a BTK inhibitor, ibrutinib, or one of the covalent inhibitors. You can use a SYK inhibitor to target some of this macrophage eating it. Then we can target the FC receptor end, which prevents because of which this antiplatelet antibody survives the endosomal recycling process. Then we can target the C1q. So C1s antibody is available to us, which we can target. So there are a host of this which are available to us, and this tells you that understanding the pathophysiological mechanism gives you a target to treat some of these patients of autoimmune cytopenias. So we have monoclonal antibodies in refractory AITP, as I told you, anti-C1s sutimlimab for ITP has already been tried, and you have FC receptor N, then you have SYK inhibitor fostamatinib, which has been tried in patients of autoimmune thrombocytopenia. So we talked about abatacept, which is very effective. I would like to leave you and acknowledge all the people from whom I've learned and continue to learn from all the young generation of people. Just to tell you that autoimmune cytopenia is not always pure autoimmune cytopenia. It is complex. Very often, it is the commonest autoimmunity you come across in uh, patients who have underlying inborn error of immune deficiency. Uh, this patient should be evaluated. Evans should have an whole exome done, irrespective, and you have lots of therapeutic options available. And many of this patient can also be cured by bone marrow transplantation. Remember, identifying underlying inborn error immune deficiency is important, because if you don't, the mortality or the survival is poorer in patients who have autoimmunity and inborn error of immune deficiency. And we have not yet seen the entire spectrum. We are going to see more and more spectrum. It is going to be a fascinating thing for all of us. And I thank all of you for giving me this opportunity and giving me this hearing. Thank you so much. Still a lot to learn.
Thank you, sir. Thanks a lot. That was such an amazing talk to make it concise, such a extensive topic in 30 minutes. And of course, we all agree that we should be looking out for IEIs in any child with Evans syndrome. There are a couple of questions. Can we take it quickly so that we'll move on to the panel discussion? One is AHA with reticulocytopenia pointer for IEI once infections are ruled out?
I don't think so.
Okay. Okay, sir. Thank you. And next is from Dr. Evitraj on your thoughts on CAR-T for refractory SLE.
Oh, you can try it. There was a beautiful talk during that Illuminate meet in which very amazing results, including results in patients who have uh, what is scleroderma, which is very difficult to treat. Dramatic responses in those things. So I think after first line failure of rituximab and steroids, and of course steroid is always going to be our favorite because we will never go out of vogue. But the third line, fourth line may soon become CAR T cell therapy. That's the way I can see how the scenario is changing.
Sure, sir. Thank you, sir. Thank you for your talk. And I think the further questions can be answered if possible, if you can reply in the chat box only, so that we'll move on to the next session, sir.
Sure.
Thank you.
Thank you.
And the next will be a case-based discussion on refractory autoimmune hemolytic anemias by Dr. Richa Jain, additional professor, PhD department from PGMR. And so the panelists will be Dr. Neeta Radhakrishnan from Postgraduate Institute of Child Health, Noida, Dr. Sagar Bhatter from Manipal Hospital, Bangalore, Dr. Satyam Arora, who is a additional professor transfusion medicine from Institute of Child Health, Noida, and Dr. Ganesh Vishwanathan, who is a hematopathology associate professor from AIMS, New Delhi. So over to you, ma'am.
Thank you, Rajita. I hope I am audible and my slides are visible.
Yes,
Hello?
yes, ma'am. It is visible, ma'am. You can proceed.
Yeah.
Thank you.
So thanks for the kind introduction. I'll jump into the panel discussion. So I'll just show this case. One who was H, a 4-year-old girl. She presented to us with progressive pallor for 20 days, respiratory distress for 5 days, and associated suck-rest-suck cycle, interrupted feeding. Had some yellowish orange discoloration of urine, no history of bleeding manifestations or fever, and she had been transfused packed red cells in Himachal Pradesh 6 days before for the anemia. In the background, her antenatal and perinatal history was uneventful. She had no neonatal jaundice, and there was family history was also not contributory. On examination, her anthropometry was normal. She had tachycardia, heart rate was 140 per minute. We attributed it to severe pallor. Icterus was present. However, there was no rash, purpura, edema, lymphadenopathy. She had hepatomegaly and splenomegaly, both palpable 3 centimeters below the costal margin. In further investigations, she had severe anemia. Hemoglobin was 2.3, as we can see. So, yeah. Though her total counts, differential counts, and the platelet counts were within normal limits, the RBC count was very low, the MC was elevated, which was attributable to the very high reticulocyte count that she had, 11.9%, and she had unconjugated direct hyperbilirubinemia, unconjugated hyperbilirubinemia. Vitamin B12, folate levels, and ferritin were normal. HPLC was normal for her age. Parental HPLC was normal. G6PD levels were normal. So I'll just show this peripheral smear for this index child here and ask Dr. Ganesh for his inputs on the peripheral smear.
Hi, very good evening. Thank you, Dr. Richa. Hope I'm audible. So
Yes, you
this
are.
peripheral smear shows significant anisopoikilocytosis. There is variation in the size and shape of the RBCs, and the arrows point to a particular morphology of RBCs, which are basically spirocytes. These are basically cells with round borders, and there is no central pallor. So that is the definition of spirocytes. Also, we can see cells which are larger, which show some bluish tinge in the inside the cells.
Right.
So these are what we call as polychromatic cells. These are basically reticulocytes. The RNA in them is basically picking up the blue stain, the nuclear material. So that is showing up as polychromatophils, which is basically a reflection of the underlying reticulocytosis. So the history and CBC findings and the PS findings put together suggest a hemolytic process which has spirocytes. So this is spirocytic hemolytic anemia. So just a word of caution. So spirocytes does not always mean hemolytic anemia. The transfused red cells also appear as spirocytes in the peripheral blood film. We need to keep that in mind. And there are two other things which are not seen here, which need to be looked out for in such a case. That is basically the presence of nucleated red cells, which are NRBCs,
Right.
and RBC clumps, which also point to a specific or some diagnosis. And also there are no organisms like malaria in this smear.
Yes.
So thank you.
So very, very pertinent points, Dr. Ganesh. Thank you. So we are looking at some kind of a hemolytic anemia with spirocytosis going on, and differential diagnosis has been mentioned. So obviously at HB of 2.3, a sample was immediately sent to the blood bank, and they called to say, please send more sample. We are unable to cross match. At this time, they also said that while we were trying to cross match, the DCT is coming in 4+. So Dr. Satyam, I'll call on you at this point to ask you how you suspect AIHA when you get a sample in the blood bank, and how will you proceed with finding an appropriate unit of blood for this child with HB of 2.3.
Thank you, ma'am. Good evening, everyone. For us, our suspicion for AIHA starts right at the spot of doing the blood grouping. So we often get an additional auto reaction doing the reverse blood grouping of these patients, and that can indicate and give us an idea whether we are dealing with a cold AIHA or a warm type of AIHA, or even a mixed AIHA. And in this case, since if there was no issue with the discrepancy, we have a 4+ DAT, and there is a history of transfusion. So we need to rule out whether we are dealing with a condition of an AIHA or DIHTR, that is the delayed hemolytic transfusion reaction. So our first aim is to rule out whether it's only an auto, or it's an auto plus an allo, which is against a rare blood group. So
Yes.
and providing blood to this patient will actually depend how serious and what is the urgency of providing transfusion. If the need of transfusion is within less than 4 hours, there will be a concept of least compatible or the best match unit, which we can provide, and that has a compatibility strength which is often selected, which is lesser than the autoantibody strength. However, if we have more time, we like to rule out a presence of an alloantibody, try to give an allo antigen negative blood, and if we know the RH and KEL phenotype, we would like to match that and provide that unit.
So in this child, her HB is 2.3 and she is an impending CCF. So the blood has to be given as urgently as possible. So I think the first time around, you will have to give the best matched blood within the first 4 hours. And subsequently, as you mentioned, further tested blood can be given when the child is a bit more stable. So thank you, Dr. Satyam. Dr. Ganesh, would you like to mention here what are the precautions to keep in mind while conducting a direct Coombs test on such a child who has been transfused outside? And what is monospecific DCT, DAT, and how is it helpful?
Yeah. So starting with the first question, so what are the precautions in general while conducting a test like a DCT? So this basically, I will divide this into, sort of pre-analytical considerations, and next comes the technical consideration. So in pre-analytical stage, I would like to take the proper history, including, the presence, including transfusion history, which is like just been recent. Second, we need to see to it that a proper blood sample is corrected. By that I mean the sample is not hemolyzed.
So, often the lab people say that a recently transfused sample should not be sent for DCT. In this child, we do not have any options because she had severe anemia and she has been transfused outside. We need a diagnosis. So would you take a sample and would you give us a report in this situation?
Yes, in such cases, if the test cannot be delayed, we take the sample, accept the sample, but add a rider in the test report saying that this is basically a post transfusion sample and it needs to be kept in mind while interpreting the reports.
Ideally, what is the interval between transfusion to direct Coombs test testing?
Basically, we advise a gap of basically 1 to 2 months, which is basically not feasible in all cases. Right. Basically, we go with if the interval is a little larger, we'll take the pre-transfusion sample before the next transfusion if the interval is shorter. Right. So that's a practical way of doing it. The practical way of doing will be that whenever we are next transfusing, whenever the child is a bit stable, that is the time when we send the sample to you. Okay, so we'll go on to the next slide now. So very briefly, an overview that a warm AIHA is typically, I think we all know this, a warm AIHA is the most common type of AIHA, which is 60 to 90 patients and is mostly IgG positive. Agglutinin disease and paroxysmal cold hemoglobinuria are the next most common. CAH is much more, cold agglutinin disease is easier to identify with a C3D positivity of more than 1:64. PCH is often a bit more difficult to diagnose, which we will come to in a bit and pick the brains of our lab people. Mixed AIHA typically has both IgG and C3D positivity here. So in this index case, we classified this child as a warm AIHA because further testing with monospecific agents showed a IgG positivity of 4+ and C3D positivity of 1:16. So Dr. Neeta, I'll take your inputs here on what further evaluation will you do before we initiate therapy on her. Please keep in mind that this is an emergency situation. For steroid is still the first choice of drug usually. So what is your steroid of choice while treating such a child? What dose and what route would you use?
Yeah, so I'll just quickly go through the list of investigations. Initially, like you've already shown, we'll confirm that and then that we'll confirm this autoimmune hemolytic anemia. These are the investigations which I've already mentioned. Just I wanted to highlight reticulocyte count. In this patient, reticulocyte count was high, but in typically pediatric AIHA, retic need not be high because you may have antibodies directed against the retics as well. So that does not indicate.
As you're saying, up to 1/3 to 1/4 patients will not have reticulocytosis in the initial 1 week of diagnosis.
Yeah. So when there is the antibody titers are very high, you may not have antibiotic response at that time. So that per se does not rule it out. But the rest of the findings which are shown here would confirm hemolysis, and then you go ahead with the DCT test as well as the monospecific DCT. Right. Next slide, please. So now you want to know, this is a 4-month-old baby. You want to know whether this is an AIHA that happened on its own or is there an underlying cause for it. So usually in children, in infants especially, infections are the common cause. So torch infections, especially CMV herpes, needs to be ruled out. EBV infections can cause parvo infections. And like Dr. Desai showed earlier, a lot of these could be patients who are immune deficient in the first place, and they are having these infections because of the immunodeficiency as well. So low-grade CMV viremia, EBV viremia can present with AIHA in infant babies. So that is something. HIV needs to be ruled out definitely in this setting. So even HIV investigation would be advised. Then coming for, in a regular AIHA, you would look for autoimmune conditions, but in 4-month-old baby, that may not be significant. So I've just listed out the investigations here just for completion's sake. So other than ANA, dsDNA, EPLA also would be tested in an adolescent if the adolescent child has come in a similar scenario. And then immune dysregulation, yes, definitely. Especially infants who are definitely XLA is 1 as well as combined immune deficiency. So serum immunoglobulin level that should detect. This is in fact recommended in any patient who has chronic DCT positivity in warm AIHA scenarios. The ALPS with double negative T cells should be ruled out.
So it is
then again,
carry on, please.
Pardon me. It is preferable to send in patients who have chronic evidence of lymphoproliferation, that is more than 6 months, and DCT positivity. ALPS should be ruled out in that kind of a scenario. And then finally, patients who have, again, older children, not so significant in infants, we do look for underlying malignancies in patients in older children who come, and they're looking for lymphadenopathy. If there is lymphadenopathy, it's looking out what the lymph node is, as in if you can do an FNAC on that, or even sometimes a marrow or a PET-CT also may be indicated. But this is more for adult patients who present with cold AIHA kind of scenario, not so significant in our
Typically,
patient.
what I've seen is that the children who present with warm AIHA or mixed AIHA secondary to malignancy often have leukemia or lymphoma, which is reasonably evident clinically at the same time as the AIHA comes to clinical presentation. I don't know if you have a different experience, Neeta, here.
Same. And many a times, just treating that condition, underlying condition may be enough. We may not have to treat the AIHA per in this.
Steroids should be started for any hematolymphoid malignancy, which would take care of the same time.
True.
Going on to the treatment part in this child with the HB of 2.3.
So treatment here, warm AIHA, the first line treatment is corticosteroids. Prednisolone is usually our first choice. Prednisolone around 2 milligram per kg per day can be started. Unlike we discussed for ITP, there are a few differences. One, the response rate to IVF, the two steroids is quite good. Around 70 to 80% patients show very good response.
Right.
And the second thing is you do not stop like in ITP or a short course of steroids are recommended. Whereas here we keep slowly tapering the steroids and you keep seeing the hemoglobin, whether the hemoglobin is falling because the antibodies are going to stay for a long time.
So for how long would you give the full 2 mg per kg per dose? Like this is a child with very severe anemia. We would probably start the 2 milligram dose here. So how long would you want to keep a full dose going? 3 weeks, 4 weeks?
If a response is static. Sometimes the response is very good. Even 1 to 2 weeks, you can just give a start and 2 mg per kg. If the hemoglobin is stable above 7 grams, then you can slowly start the tapering. Initially, for the 2 gram hemoglobin, of course, you will transfuse at that point of time. But eventually, you can get to know that if you have transfused at a 5 and then it became 6 or 7, and then it is not falling further. So that is itself an indication that you can your hemoglobin has now stabilized. The antibodies are not the steroid is helping in the condition.
When would you give pulse methylpred?
That would win.
When would you give
steroids? IV steroids are indicated if the patient is sick. As in patient is sometimes the children, especially patients who have this can be
2.3 HB. Would you give pred or IV methylpred?
If the stable prednisolone is okay. If the patient is vomiting, patient is in CCFP, you're not sure about the oral dosing, then IV
or absorption, then we would give the IV methylpred pulse. Right.
And sometimes they come with like older children who come with like crashing and coming with CCF. At that point also I've given pulse methylpred 30 mg per kilo.
Right. In that case, we would give the 30 mg per kg dose. That is one of the few conditions in which we use that dose. Thanks.
Yeah.
So this index child, she continued to, despite the high dose of oral prednisolone that we started her on, so she continued to have repeated anemias, swollen hemoglobins, and transfusion requirement over the next 1 month. Continued to have direct and indirect hyperbilirubinemia and high reticulocyte count. And though the DCT decreased fractionally from 4+ to only 3+, and the further assessment, as Dr. Neeta has mentioned, was all negative, this was not a very good steroid response. So IVIG was given twice to her. So, Neeta, over to you again. What are the risk factors for refractory AIHA?
So, refractory AIHA, whenever it is in the extremes of the pediatric age group that we see, so infants as well as adolescents, there is higher chance of having an underlying condition and having a refractory presentation, a refractory course. If the disease is insidious in onset, many a times rheumatological conditions will present with an insidious warm AIHA. So it's been going on for almost 6 months, 1 year kind of presentation, low-grade hemolysis, which is receiving transfusion, child is not very sick. That kind of an insidious presentation also, it is generally secondary to another condition, from mostly SLE. Then again, it will last. It has a longer course. Say all secondary AIHA, whether it is rheumatological conditions, whether it is immune deficiency, immune dysregulation, again, HIV, these conditions also long course. and other autoimmunity. So AIHA with another autoimmunity, for example, thrombocytopenia, patients with vitiligo, nephritis, all of these presentations, again, there is something else which was there, which we have to identify.
As was mentioned in the initial talk. So Sagar, over to you. What evaluation at this point do you advise in this child who has not had a response for the last 4 to 6 weeks? And what is the role of genetic testing in this situation?
Thank you, ma'am. Thank you for the opportunity. I hope I'm audible.
Yes, you're audible. Nice to see you, Sagar. Hi.
Yeah, seeing you after a long time. Nice to see you. So I think there has been enough discussion on AIHA so far, and also the first talk has made my life easy, where I think everyone would be convinced that when you see AIHA or EVANS, one needs to think about an underlying genetic defect. I'll keep it simple. Extremes of age is a problem. I think generally AIHA starts between 5 to 8 at a very young age. Now, this is the monogenic disorders will be very high on cards. On the other hand, if you have adolescents, then autoimmune disorders, predominantly lupus, will be very, very high on cards. So this child is the infant number 1, and this child has got refractory AIHA number 2. I think these two are good reasons to think of an underlying genetic
what
defect.
testing would you advise? What testing would you do?
I think ALPS would be one thing, but I think you already told me DNT is negative.
Yes. So at this point, we have IG profile, which is normal. We have BT NK cell subsets, which are normal. IG profile is normal, and a DNT, which was all done because she was an infant presenting with AIHA. These were normal. So, but still, we are dealing with the refractory AIHA. So, what is the next line test would you do? Would you go for a whole exome, a genetic panel, something else? What is the test?
So one test,
specific test.
One test I may do is to look at hypomorphic skid, to look at the lymphocyte subsets in great detail, to look at the naive T cell counts. We have had at least a couple of kids with RAG deficiency who presented.
So what is
with
the testing
AIHA.
then? What is the name of the test?
We call it here the comprehensive lymphocyte subset assay, and specifically the lab tries to look at the naive T cells and the recent thymic immigrants, basically to see that look at the thymic output, because occasionally you may have a normal T cell count, but if the thymic output is poor, that typically happens with hypomorphic kids with RAG deficiency, and they can present.
So
and the straightforward test would be possibly, I'll do that, and this would naturally be followed by exome sequencing in this child. I'll go for a whole exome sequencing.
So would you do them simultaneously, or would you order them? Sorry, Sagar, would you do these two simultaneously, or would you order them one by one?
If I have a facility for looking at recent thymic immigrants, the result should be back in 24 hours. So it's a matter of 24 hours. However, I think I would definitely send an exome in this situation.
Right. Thank you. So, Dr. Neeta, what is your choice of a secondary agent in this child? She has failed PRED and she has not had a response to IV, 2 doses of IVIG. How do you proceed in a child who fails prednisolone?
Yeah, so IVIG is not a secondary agent. IVIG is one of the treatment options we can give along with steroids. That is there. But in this case, she has failed that also. Then the next obvious choice is rituximab. So rituximab, the classical dose is 375 mg per meter square per dose. Sorry.
So Neeta, do you stick to this dose or do you try alternative doses? 100 is also talked about. What is the dose you prefer?
Yeah. We can give lower dose also. 100 mg per meter square per dose weekly as well is also recommended. There are studies which have shown that there is a response. And rituximab also has generally CR rates of 70 to 80% have been described in AIHA with rituximab. So that again is also better than ITP. So both of these so all this B depletion, steroid, all these things work better in AIHA scenario than ITP. And usually response comes in within 1 to 2 weeks only. And so median response has
How many doses of Ritux would you give before you say it is non-response to rituximab?
So there are, as in the classical teaching is 4 doses.
Right.
There are a lot of people after the 3rd dose can even look at the CD1920 and then decide whether to give one more rituximab or not. If it is not responding, then why give it again? So that is also a thought process. But usually it is given for 4 weeks.
Right. So, Dr. Sagar, would you like to comment on use of sirolimus or MMF?
Yeah, sirolimus, I think I would use if it is refractory.
Very briefly, please.
However, I may use sirolimus upfront or a bit earlier if I know the underlying etiology is ALPS or LRBA deficiency, CTLA4 haploinsufficiency. So for certain specific
So it
disorders,
is the drug
I
of
may use
choice if you
sirolimus
have
a bit
identified.
earlier.
Yes, it is the drug of choice for ALPS or LRBA. Right.
Yeah.
But in case you don't have a definitive diagnosis, it is still high on the cards for a third line therapy at this point. And what about MMF?
Yeah. I haven't used MMF a lot, frankly. So I would think that if somebody is not responding to sirolimus, I'm not sure whether they would respond.
They will respond to MMF.
Very little.
Right. So, Dr. Neeta, your thoughts on splenectomy and MMF?
Yeah, MMF we used to use earlier. Nowadays, not so much. Danazol is
Right.
some another agent which I have seen rheumatologists prescribe, and they somehow warm AIHA. The response is very good. So you can take off steroids if there is response to Danazol. And these are the other agents, daratumumab and bortezomib, because sometimes the reason why it is refractory is that we are not able to remove the long-lived plasma cells. So if you give
have you tried bortezomib in any
daratumumab,
refractory AIHA as yet?
not in this scenario, but refractory alloimmunized patients, we have tried. Couple of patients we have given
It does
bortezomib,
work
and the
quite well.
response has been good.
Yes.
Yeah, it works well.
Yeah.
So that's how refractory. Earlier, splenectomy used to be considered, but nowadays, splenectomy has issues of complication. Better second line agent. Because of that, splenectomy is almost not considered.
It's almost out of
the guidelines. Patients who fail, but it's very difficult to manage patients. This kind of scenario, hemolysis, if you have a splenectomy, risk of thrombosis also goes up. So it is.
Have you ever splenectomized AIHA?
No.
Right.
Not
so
yet.
Our experience thalassemia who have absolutely failed all kind of therapies for refractory antibody as well as alloimmunization, primarily followed by autoimmunity as well. So children very, very refractory at times end up getting splenectomy, and then they do have some response to it. But like Dr. Neeta has said, it comes with a lot of complications, including in the second and third decade of life with pulmonary hypertension and thrombotic complications. So the index case received 19 transfusions and 4 months of high-dose steroids, 10 doses of rituximab actually, and improved at 11 months of age, 7 months after onset. And NGS for inborn errors of immunity was interestingly negative and currently very developmentally normal. So we had a similar case, a 2-year-old boy with DCT positive mixed AIHA, steroid for 4 months when he came to us about 2 years ago, and had biallelic mutations in ADA2 gene confirmed by sequencing, as we can see here. And one of the mutations is pathogenic, another mutation is of uncertain significance. So ADA2 levels were also done in-house and they were low. So ADA2 has been covered in the initial talk. So Dr. Sagar, would you quickly like to talk about the management of this child?
Yes, ma'am. So basic ADA2 deficiency has got, I would say, 2 kinds of presentation briefly. If you have some ADA pan-like vasculitis, nodosa, completely absent ADA2, you usually develop PRCA, pure red cell aplasia. So I haven't myself managed the child with ADA2 deficiency with AIHA, but I believe that TNF blockers, especially adalimumab, works very well, especially when it comes with vasculitis-like presentation. I think that should be the kind of management, especially if the child is steroid dependent. So I would possibly try that therapy, because typically in ADA2 deficiency, adalimumab, etanercept kind of works very well. But I'm not sure what happens in AIHA.
So because we are already at 8 o'clock time period, Dr. Shweta and Ajita, though we did start a bit late, do you want me to continue the panel discussion? We have about 10 more minutes of slides left.
You can continue, Richa.
Okay, Shweta, thanks. So we have a second case, a 6-year-old boy who presented with fever for 3 days and now was afebrile for 4 days at the time of presentation. He, however, had lethargy and breathlessness for 24 hours, had tachycardia, tachypnea, bounding pulses, severe pallor, no icterus, and a hepatomegaly was present, but spleen was not palpable. His CBC showed severe anemia, HB of 4.3. Again, the TLC, DLC, and the platelet count was essentially normal. MCV was 130, and MCH and MCHC were quite elevated as well. Reticulocyte count was 12%. Bilirubin was 1.3 with 0.5, so not really very elevated. LDH was elevated. There was no evidence of malaria on the peripheral smear, which Dr. Ganesh has mentioned previously. Urine HB and plasma HB were within normal limits. So, Dr. Ganesh, you were mentioning something when you were talking about the peripheral smear in the first case. Would you like to comment on this?
So, this is the low magnification peripheral smear. The findings are very striking. We can see large agglutinates or clumps of red blood cells. So, one
Right.
This from Roulet, which is basically regular stacking. This is irregular, clumping of red cells, and this is typically seen in autoimmune hemolytic anemia. Especially such large clumps are seen in cold autoimmune hemolytic anemia.
Yes.
Though this can be seen in warm, but more common and more severe in cold. So we need to keep in mind. I need to recall the CBC findings. So when we see this on the smear, we don't really trust the MCV and the RBC counts. They may be falsely altered.
Yes. So this MCV is actually erroneously elevated because of the large
so it's
clumps.
Not just the large clumps are passing through and they're being counted as individual RBCs, and also because the RBCs are clumped together, the individual RBCs are not being counted properly. So there is an undercounting of the RBCs. So a simple method to confirm this is basically we can warm the sample 37 degrees, we do the CBC and the PS. So typically we see a correction in these two values. The RBC count increases, MCV decreases, and also the RBC clump reduces significantly. So that is simple because of
very pertinent. Yeah, thank you so much. So a DCT was done here and was positive for C3D high titer, so suggestive of cold AIHA. So Dr. Neeta, HB is 4.3. This child has some tachycardia. How will you manage this child, and what is the expected case of cold AIHA?
Yeah, so while we wait for the transfusion department to give us a compatible and a least incompatible unit, we will prevent cold antibody AIHs are typically triggered with cold temperatures. So if you cold temperature promotes the binding of IgM antibodies to the red cell and then start triggering hemolysis. So you want to reduce cold exposure, especially in the acral parts of the body. So ears as well as fingers, toes, etc. You keep the baby warm. So you can use warm blankets, use socks, etc. And to prevent exposure to cold temperatures as well. So that is something that we can do meanwhile. So, and now along with this, or if you're giving fluids, etc., you are supposed to warm all the products. So blood warmers can be used here. Warm
inline warmers are available. Yeah, so inline warmers are available and they can be used very easily.
Yeah, most PIC units have it, so it can be used. Again, managing severe anemia, least incompatible unit has to be given. So generally, the transfusion unit department identifies a unit which is least incompatible. Again, use a blood warmer for here as well as transfuse slowly while maintaining the warming. Cross matching definitely would be difficult, but then that should not be the reason not to transfuse. Maintain hydration. Now here intravascular hemolysis is happening, and so because of that there will be hemoglobinuria, renal dysfunction early. So you have to prevent, you have to maintain a urine output going, also monitor hemoglobin renal functions quickly. And finally, many patients in pediatric age group, the cold antibody is usually triggered by an infection. So you look for mycoplasma, EBV infections, etc. Mycoplasma is easy, so difficult to prove mycoplasma. So many times we end up treating
empirically end up giving the azithromycin here.
Yeah.
Right.
And viral infections are also common. So in my experience, I have seen 2 children with CMV with cold antibody, and children actually responded only and need not require any further treatment for AIH. And once the CMV copies came down, it improved as well.
How old was the child?
So that was also an infant.
Okay, very interesting.
So that was an infant and treated only with anciclovir and improved. So that these are
so often the thought is that cold AIHA, it's the warm and the mixed AIHA which are associated with secondary causes of AIHA, but more and more evidence is coming in that a lot of pediatric cold AIHAs are also secondary, not just to infections, but also to some deficiencies. So we have to keep that in mind in a child who is refractory. So, Neeta, you mentioned difficulty in cross-matching. So, Dr. Satyam, I'll ask you, how frequently do you see difficulty in cross-matching in cold AIHA versus warm AIHA?
So it's very common when we get a cold AIHA case, and apart from cross match, we also get issues with grouping, and it becomes very important for us to collect this sample at 37 degree when we're evaluating a suspected case of cold AIHA. And often resident goes to the bedside and collects from 37 degree via syringe, so that it can be separated. The red
So it
cells and
has
the
to be
plasma can be
transferred
separated.
immediately to the blood bank in a
Yeah.
warmed,
Yeah.
in a, like it should be warm throughout.
Yeah, yeah. And even collected through a warm syringe. So and
Yes.
then we can separate it, and that helps us in evaluating whether any DL antibodies are there. And we also look for antibodies against P antigen and I antigen to rule out
Okay.
whether it's a cold agglutinin disease or a paroxysmal
Paroxysmal cold
hemoglobinuria.
hemoglobinuria.
Yeah.
Right.
So just to differentiate between that. Yeah.
Right. So clinically, PCH has more of intravascular hemolysis, while cold AIHA has more of extravascular, still
Extravascular.
liver-related hemolysis with less of plasma and urine HB elevation. But yes, the lines can get blurry very easily in these two,
Yes.
between these two entities, clinically as well as laboratory-wise. So in the index child, blood was transfused, as Dr. Neeta has mentioned, with the warmer, best compatible, folate azithromycin was started. Hemoglobin improved but dropped again after 48 hours. Typically, we think of cold AIHA as a disease which would not require a lot of transfusions, at most a single transfusion. But this child did not behave very typically and continued to have recurrent hemoglobin drops. So, Dr. Sagar, how frequently are non-infectious secondary causes seen in cold AIHA?
So, as such, I would say cold AIHA as such is very uncommon. And second thing is, even when you see cold AIHA, it is infections which are very common, like we discussed, mycoplasma and EBV. So if you see a non-infectious cause of cold AIHA, then I would start thinking of an underlying immune dysregulation.
Yes.
Something like CVID, ALP, or those kind of immune deficiencies. Though again, in immune deficiencies and in autoimmune conditions, warm AHA is again more common than cold AHA. So, but then yes, this is a rarer subset, and if you have a refractory cold AHA, no clear infection, then one should think of
I should be assessed for in this situation. So, Dr. Neeta, what is your preferred second-line therapy in this child? And also, please share your experience.
Cold AIHA, steroids are very limited role because the is not in the spleen, mainly not in the spleen. Splenoid. An agent is usually rituximab, and here, but the response is not that great. It is usually around 50% only. Plasmapheresis can be tried. Plasmapheresis, although it's as in because it's the IgM antibody, it's mainly in the intravascular system. It can be removed by plasma exchange. It is supposed to be more effective. It's one of the category 2 interventions for cold AIHA.
And so this is a good intervention.
It's a short-term measure, but you're removing the antibody, then again antibody will be produced. So that's a different thing. You need to identify the source and then treat that. Because but for a critical scenario, when the patient is not responding, that can be a few sessions of. I personally have not used plasmapheresis.
So I have used Plex in like only a couple of cases. I think this was one of those children who did improve after that. So very quickly we will and briefly we will talk about case 3. She was another complicated 7-month-old girl who presented with a 2-week history of jaundice, reduced activity, reduced feeding. However, there was no fever, bleeds, oral ulcers, no abdominal distension or high colored urine, no drug intake, no transfusions. Antenatally, she was like totally uneventful history of normal weight baby, no jaundice, no history of transfusions of family. Right. So admission outside hospital was about 15 days ago with a HB of 3.9 gram percent, where PRBC was given. They did not find a difficulty in cross-matching outside. Post-transfusion HB rose. And however, within about 5 days, she came back with a similarly super low HB of 3 gram percent with requiring 2 packed cell transfusion. Again, they did not report any cross-match difficulty, and the post-transfusion HB rose to 9. At this point, she was referred to us. In the physical examination, her anthropometry was normal, her vitals were normal. At the time of presentation, she did have pallor and icterus. No hemolytic facies were present, and she had a hepatomegaly 4 centimeter below costal margin, but no splenomegaly. During our ward stay also, she continued to have repeated drops in hemoglobin over the next 2 weeks. Her TLC remained okay. There were fluctuations in the TLC, but more or less the absolute neutrophil counts were within normal limits. Her platelet normal, MCV, MCH, and MCHC were high, very similar to the second child, very, very high MCV, MCH, and MCHC. Reticulocyte counts were very high. The corrected reticulocyte counts were also quite high. At 6% and 5.4%, 8%, 11%, and RBC clumps were seen very impressively. Hyperbilirubinemia, primarily unconjugated, was seen. AST was elevated and LDH was elevated. Again, as Dr. Neeta pointed out in her initial slides, they were looking more like a hemolytic process going on. So high reticulocyte count, RBC clumping, extremely high MCV, MCH, unconjugated hyperbilirubinemia, elevated AST, LDH. However, the DCT, when we sent it, came out negative. So, Dr. Ganesh, what are the causes of a false negative direct Coombs test, and what further testing can be done in this child?
Yeah, so there can be a few causes for a false negative DCT. So important, we need to differentiate this between a pre-technical or pre-analytical and a technical causes of false negative DCT or DAT. So improper sample collection, stored samples, and delayed transportation. Improper use of anticoagulant. These are all can be causes of pre-analytical errors. And also the technical part, we see to it that there should be adequate washing, because unbound antibodies can bind to the Coombs reagent, and it can lead to false negative DCTs. And we need to keep in mind the prozone phenomenon, where the amount of antibody can be too high, and that needs dilution. And also, if there is
so in a false negative DCT, if the clinical suspicion is high, further dilution needs to be done.
Yeah, that is one thing. And we need to use controls properly. Positive and negative control should be put up with each test, and we need that the reagents which we use are valid. And there can be low titer and low affinity antibodies. The typical DAT is positive when there are few hundreds of immunoglobulin molecules per RBCs, like 100 to 400 is the range. But if it's lower, then then the typical tube-based test may not be sensitive. So in that case, we can use sensitizing reagents like a LIS reagent, it's a low ionic strength solution,
so
or something like a
tube test, or do you use gel tests at this point?
So in our lab, we use a gel card test.
Majority of the labs probably in the bigger hospitals using gel card tests at this point of time. I think PGI also uses gel card. So is it possible to miss with gel card? I think its sensitivity is better than the tube test.
Yeah, its sensitivity is better than the tube test. So still it would require like a few tens of antibodies. If the antibodies level is too low, then I think a flow cytometry would be a much more sensitive technique. It picks up even very low levels of immunoglobulin molecules per RBCs.
So what flow cytometry should be asked for if we are stuck in such a situation?
So basically, the flow cytometry is antibodies against the coated immunoglobulin. So it's basically a anti-IgG antibody which is used. So basically, the technique is slightly different. It is a flow cytometry based technique. Otherwise, the principle is the same.
Is it something which is easily available? Where would it be available? Or can it be
so it's not routinely. I don't think it is routinely available, but it's the assay can. We do see a big center saying immune anemias or immune related conditions.
Another question: how frequently is IgA antibody AIHA negative on the gel test? We often see IgA antibody as one of the reasons for a possible false negative DCT in the theory. How frequent is that, in your opinion?
We don't use IgA in our antibody. Maybe blood bank or Dr. Satyam can say, but the typical polyspecific that contains reagents contains IgG and C3d, and monospecific one test them individually. I mean, the literature says it's pretty rare, but I don't have a personal experience with the use of IgA.
Right. You, Dr. Satyam, would you like to comment on that, and also on assessment for PCH with donatlantin antibody?
Yes, ma'am. So now the monoclonal DCT cards have an option of detecting an IgA antibody-induced DCT, and we have actually published a case on that negative IgA-induced AIHN, which was because of high clinical suspicion that we were able to pick up. Another important thing with regard to warm AIHA, now we where we can differentiate this warm DAT positivity of IgG between IgG1 and IgG3.
Okay.
And if we know if it is IgG1 or G3, we can even dependent titers of IgG1 and IgG3.
That will help us
And
look
one
for
of the
the
case series that we
to therapy.
Yes, and one of the case series which we published from our institute in Noida, we saw that if the titer is of IgG3 was higher, it made it a strong point of starting steroid with rituximab because these patients will eventually become resistant to steroid therapy. Now, coming to the DL antibodies, it's very important that we collect samples for these antibodies at 37 degree and we separate the red cells and plasma as soon as possible. And when we have to screen them, we are suspecting antibodies against P antigen. So we make 3 tubes. In one, we add the P positive cells, serum, and the complement, a fresh complement which is there from our donors. And the second tube, we add red cells, plasma, and fresh complement, and keep it at 4 degree. And the third tube, we keep it at 37 degree. And if we get a positive reaction with the cells which are positive for P, it indicates that we have a GL antibody in this case. And negative DCT, it can be because of low titer of these antibodies which are there. Often very acute phase of the disease where most of these complement which is attached to red cell gets dissociated. So a lot, apart from the pre-analytical issues which Dr. Ganesh has mentioned, even the activity of the cold AIHA can influence the DAT positivity with us.
Right, thank you. So donatlantin antibody testing is a bit of a tedious process as I understand it, and it takes quite a bit of time and effort. However, it was done in this child. DCT was negative, plasma HB and UHB were normal, donatlantin antibody was negative, and parental and G6PD, parental HPLC and G6 activities were normal, and viral assessment, infectious markers were all negative. So, Dr. Neeta, how would you proceed in this particular child? Would you do genetic testing? Would you do any further evaluation? And what will be your treatment decision here? We are a bit stuck because the child continues to have repeated drops in hemoglobin.
Yeah, it's a tough patient. So, or all the cases that have been described, I saw that you have done G6PD also. So, whenever DCT negative hemolytic anemia, it could be a completely different diagnosis also. So, G6PD is something we also would check. Sometimes I've seen patients who are non-transfusion dependent HAL who are never picked up earlier, who probably were maintaining hemoglobin around like 8 or so, and then suddenly have an infection, got a transfusion outside, became aluminized, and suddenly they come like this. So that also is a possibility. So HPLC helps there. Sometimes spherocytosis.
So we had a parental HPLC for that particular reason exactly, that whether it's a thalassemia, as you mentioned, with the alloimmunization, but it was normal.
And sometimes spherocytosis also. Child had mild HS throughout and never picked up, and then there is an aplastic crisis of an infection has come in. So here the
that's a very good
high,
differential. Yes,
that also can come like this. So these are difficult scenarios. Definitely a genetic testing would be warranted.
Be indicated here. Yes.
Going on at this thing, but we would give a trial of steroids. Steroids as well as IVIG definitely would be tried. By the time you have like 3 to 4 weeks and nothing else works, and if your genetics is normal, then probably consider rituximab at that point of time. Otherwise, PCH, if it is PCH, again, very difficult to diagnose. You need a very good transfusion support to pick it up. And many a times it is post-infective, so it generally responds on its own.
So, Dr. Neeta, I will ask you, how frequently do you actually get a positive donatlantin antibody in a child you are suspecting PCH? Have you ever seen a positive?
No.
Because we keep on sending, but we don't get a positive. And it's a self-limiting illness. The child improves within a few days. So is that your experience as well?
Also. Same. That have sent multiple times, and 2-3 times the child has improved on its own and without anything, just transfusion support once or twice and just improves. So it could have been PCH retrospectively.
Right. So, however, the amount of transfusions this child was requiring was reasonably unusual. So, NGS was done in-house for hemolytic anemias, hemoglobinopathies, and inborn errors of immunity. Over the next 4 to 6 weeks, they gradually came and they were all negative. So we were still stuck with her. This child was still requiring repeated transfusions, and our best bet was still a DCT negative AIHA, keeping in mind the clinical presentation and the investigation. So we gave a trial of steroids, as Dr. Neeta has mentioned. We did not see any response. A trial of rituximab for 4 doses were given, and she's become transfusion independent and currently is well. We still don't have a definitive diagnosis, but the child is well. So I'll just ask Dr. Sagar a last question. How frequently do you see patients with IEI presenting primarily with AIHA and vice versa? AIH, I think that has been covered very well in the initial talk, AIHA and IEI, but how frequently do you see isolated AIHA as the primary presentation of IEI?
I wouldn't say it's very common. Isolated AIHA, often when the patients present with autoimmune cytopenia, if you take a detailed history, you would often see that they have had infections which have not been picked up, or they've had a positive family history which was not given a credence. So we often see that there was something beyond AIHA, though yes, theoretically, especially patients with CVIDs sometimes can present with AIHA. And I've seen patients with Wiskott-Aldrich syndrome who had the diagnosis and then went on to develop AIHA.
Right.
And patients with ALPS who presented upfront with AIHA. So it is possible, but then generally only isolated AIHA is not that common. And yes, a lot of our patients on follow-up have developed AIHA, especially our CTLA4,
so
LRPAs.
It's very common to see known
VAS.
IEI developing AIHA, though all said and done, AIHA as the primary presentation of IEI is still very, very valid presentation, but a detailed history and examination needs to be done. So another question, Dr. Sagar, which we often face in clinical practice, how do you determine the pathogenic relevance if the genetic testing reveals variant of uncertain significance? In our DADA2 deficiency patient, DADA2 patient, we had one pathogenic mutation and one VUS. So how or you see isolated heterozygous mutation and genes typically associated with disease in a homozygous. How do you, one last question for you, and then we'll stop the panel discussion.
Yeah, so these are real life challenges. One simple thing would be if you had a functional study, like you got ADA2 levels done.
Right.
So that can be done. Life is simple, it is easy, and you have sorted the problem. If not, then we have to go back to the lab and say that my suspicion is very strong. There is a possibility that there is a large deletion which has been missed on an exome.
Yes.
And a good lab may work and do something called MLPA or chromosomal microarray to pick up the large deletion. These days, there is
so
a
the
talk
clinician
about
needs to be aware.
Again,
the clinician needs to be reasonably sure of their differentials and be aware of these testing. We cannot depend on the lab, a single lab test to give us the entire diagnosis.
And we should try to get functional studies done. For example, if there is a protein expression study, those things would really help.
How frequently would you advise Sanger sequencing in a difficult to diagnose patient in the parents and the rest of the family? That would also at times help us establish a diagnosis. So any other last minute thoughts? Neeta, anything from your end? So one question often which Dr. Neeta wanted me to ask you, Sagar, was how do you check for IG levels before starting rituximab if it has otherwise not been checked?
How do you check? Sorry, ma'am, I didn't get. How do you check?
Do you check immunoglobulin levels before starting rituximab?
Yeah. Yes, as a principle, I always check immunoglobulins, obviously CD20 assay, because we have burnt our hands. We have had CVID patients who have been given Ritux and then they come back and you are debating which came first. And it becomes very, very difficult. In fact, we have a series of Ritux-induced hypogamma patients.
So tell me something. If you do not have if you have a diagnosis of, say, AIHA or something else which requires rituximab, and you have low IG levels and low absolute B cell numbers, would you proceed with rituximab provided a contraindication is ruled out?
I think it's not an absolute contraindication to give Ritux, but then I know that I'm dealing something bigger than simple AIHA. I'll possibly send an exome, give Ritux, try to control AIHA, but I'm looking at a broader picture. So it's not an absolute contraindication, but the story will not stop with Ritux mostly.
Right. Thank you. So thank you very much, Neeta, Sagar, Satyam, and Ganesh. It was a pleasure to meet you all. Thank you, Dr. Shweta, for inviting me for this panel discussion.
Thank you.
if I'll stop my slide share here. Any specific question, Ajita, which any of us need to address?
I think most of the questions have been answered by the panelists and Dr. Mukesh in the chat box. It was just about the second line agents and the choice of agents, etc. And it was a wonderful panel discussion. You had covered all the pertinent and the practical questions on refractory AHA. Thank you, ma'am.
Thank you.
And we did learn a lot today. So first is starting with Dr. Mukesh Desai's talk on IEA and autoimmunity, where he rightly highlighted like how we should always do a sequencing in any child with events, if not for only IHA alone. And of course, the various scenarios they have seen at Vadia, where the children have had T regopathies or ALPS or rare scenarios like STAT3, GOF, etc. And from your panel discussion on the various agents we have tried, so there were one or two questions about the use of daratumumab in immunizations. So those kind of scenario, if you can that alone, have you used daratumumab in?
I have no experience with the use of daratumumab. I don't know, Sagar, Neeta, if you either of you have any experience with it.
No, I have not used, but I think it is being used in many centers in this refractory setting. So I have not used. Maybe I think I've heard Anand. I think Anand had as a patient, but otherwise I have not used.
Thank you, ma'am. I think Anita ma'am had also answered all the questions then and there. So since it's already late, we'll close the session.
We'll
Thank
close the
Thanks
session.
a lot.
Yeah. Thank you, everyone.
Thank you, ma'am.
Thank you,
Pleasure to be
everyone.
here. Bye.
Thank
Thank
you.
you, doctor.
Bye.
Thank you.
Thank